The executive board of the WHO unanimously passed a plan for a resolution for May of 2015, and it's about strengthening emergency and essential surgical care as part of universal health coverage. And at this moment, there are several global surgical organizations. They are surgical, obstetric, trauma, and anesthesia care organizations that are coming together to talk about ways to provide this kind of care to the people who need it the most. There's so many deaths and so many millions of lives that could be saved if this goes really well. And this is something that our generation has the power to actually make happen today, right now. The important thing about this resolution is that it needs people to make it happen. And it needs organizations and groups who have already been doing this kind of work on the ground to be involved in this kind of effort. And one of them is the FIA Foundation, who's done an amazing job with the Decade of Action for Road Safety. If we don't talk about putting surgical care in the national health policy, if we don't begin to talk about providing actual care to people, it's not going to happen.
Road traffic accident is a forgotten epidemic in this region and this country in particular, because it does account, as we said, for 65% of those who are injured. And we have spent a lot of time in the developing world on the infectious diseases. We have improved it to some level, but if we continue to just concentrate on the infectious disease side, then we may be losing the battle in the end, because we shall bring forth healthy children by improving their infant mortality rate and childhood diseases, only to lose them to road traffic accident.
We see patients arriving at district hospitals already in a very bad state. But if we think about actually taking care of these patients at point of care, very far away, you identify health workers who are very good, train them up a little bit, give them knowledge about first aid, ABCs, management of the trauma patient. They will be able to resuscitate the patient really well, and they will be able to make sure that the patient, while in transport from the rural area to the district hospital, will actually have a good chance of survival and a good chance of having a good prognosis. Then that saves so much in terms of disability and even premature death. And that's something that has been proven in many countries, in Cambodia, in Bangladesh. And it's something that just needs translation. It's something also that the government has to be aware of. And it doesn't cost very much. It's very cheap. Train them up, even just for a few weeks. And if you give them that capability, give them a little bit of supply, give them the equipment, then they know what to do. They won't feel desperate. They will feel very capable, and they will get it done.
The road that we are at is a road that is linking Kenya and Uganda. At the spot where we are, it is where we get a lot of calls for accidents here. St. John Ambulance was able to put up a facility for training the community members, just like the ones who are behind me. They are always here to respond to the emergencies. The headquarters where our ambulances are is 10 kilometers away. If an accident has happened here, the community persons whom we have trained will be the first ones to respond. We all know that the first response that is given to the accident victim is so important for the person to survive the next days until he gets advanced care.
If the injury occurs in a remote area, if the paramedics in that region are not there on time, if the doctors are not well trained, if the hospital is full, people are dying, people that could have been saved by this kind of technology, which we do have. The skill and technology is there. It's just not enough. That those resources in this part of the world are finite. There's a cap, there's only so much.
The systems are not there, meaning the systems to take care of these people who get into accidents. If we look at the Sustainable Development Goals right now, there's one goal for health, and there are many, many targets. There's one big target for universal health coverage, and under that, to strengthen essential services. But if I look at, for example, Ethiopia's National Health Plan, and it lists essential health services, it lists contraception, reproductive health, there's no specific line that talks about essential trauma care. And that's something that we need to change. People think that surgery or trauma care is an option or it's a luxury. It's not, obviously. It's something that everybody should have access to, and it's something that's very simple, it's very basic.
When you talk about sustainable development, there's no way you could talk about that and not talk about road crashes. Because we forget that the cost of a crash begins from the site of the incident, but follows the person for the rest of their lives. My work now revolves around interacting with institutions like the National Spinal Injury Hospital, where I offer counseling services to road crash victims. This is where you see a person from a very poor family choosing to die instead of going back to the society because he knows or she knows that the society will not accept them because they will not access any basic facility.
This problem of road traffic accident is made worse by lack of resources and by use of traditional methods in treating these people. Budget allocation does not give provision for implants, which is used to treat the fracture victims, and therefore we normally call upon the family members to buy these devices themselves.
Is there interest from private companies in working directly with Kenya?
These are some of the old school type of nails you'd use to fix a femur. It's a kuncha nail, and we still get them made in India, and that's the cheapest device you'd use to fix a femur. It will cost a patient about $15–20 to get it fixed. But considering that majority of these people live below $1, so it will still take time before they can buy this. The most standard one, which is called an interlocking nail, will cost them about $500 to $1,000. That one is definitely very few people will be able to afford that.
$500 to $1,000.
Yes. If we use this, we can be able to allow the patient to start walking in 6 weeks' time. While if we use the interlocking nail, we'll be able to allow them to start walking within a week or two. So definitely we see the advantages.
We often focus on the fatalities, the 1.4 million people who die every single year as a result of road traffic injuries. But for every one of those deaths, there are 10 to 15 serious injuries that leave people with long-term disability.
In 1980, the Director General of the WHO, Dr. H. Maller, encouraged the global surgical community to invest in essential surgical care. He said, your actions today will determine if people in the next millennium will have access to these basic surgical services. 34 years later, we're still facing the same situation. There is a window of opportunity now and in the post-2015 era to change this, to change the course of history for global surgical care. There's so much at stake in terms of lives saved, in terms of disability prevented, in terms of economic growth that countries can have. And the time to act is now. We can't hesitate and ask ourselves if this is the right thing to do or not. This is something that's very obvious. It just needs the right push from the right people in the right direction.